One of the most common questions I get, and also I used to think of, is when we're doing a composite, let's say you're doing it under rubber dam, posterior composite, are you supposed to make the anatomy look like what that tooth is supposed to look like in a textbook? I.e., are you supposed to basically recreate the textbook in the patient's mouth? Well, do you know what happens when you do that? Well, this is what happens. Yeah, the patient bites together and you have to rub it all away. You have to adjust all that hard work away, and now it looks like a flat white version of amalgam. So what's happening there? How can we be smarter? How can we use the textbook as inspiration, but also just not end up making all our restorations flat? It's a real fundamental and basic question in a way, but I think it is so real world. So we are covering today tooth morphology with our protrusive student, Emma Hutchison. This is PS005. Remember, this is a series we're making with Emma throughout the year to cover themes which are relevant to young dentist students and those who are perhaps re-engaging back into dentistry, and also for all dentists who just want to dip into the basics again. I think there's a real beauty in seeing how far you've come and how much you've progressed by going through the basics one more time. We were going to talk about orthodontics and stuff, but really as a student, I thought I wanted to make it more applicable to the real world. So we deviate more towards tooth morphology, and I hope that you can apply some of these tips in practice. Or on the mannequins if you're still a student. Remember, if you're a student, you get access to a few secret areas in Protrusive guidance. All you have to do is send your proof to student@protrusive.co.uk, and of course, download Protrusive Guidance app, and then we will link you up to the right space so you get access to a few special features. Let's catch the main episode, and I'll catch you in the outro. Welcome back everyone to May's episode. Emma, how is it going? You told me that you just fit your first denture.
Yeah, so last week I had an elderly gentleman in who needed a new lower overdenture. So I've spent the last however many appointments going through all the processes.
Yeah, Emma, for those students who may be a little bit more, junior to you, even the term overdenture might be like a new one. And that's strange actually how it's your first denture, because we at dental school, it was complete dentures that we did. So tell us, what is an overdenture, and is that standard for you guys to make an overdenture as your first denture?
I don't think it's pretty standard. So basically my wee patient, all of him, he was so nice. He had 2 on the lower, which I had in a previous student had decoronated, and we kept the roots in there to sort of give you a bit more bone support and a bit more just support for the denture. And that's proved to be really good for him. So you make the denture fit in over these roots and that alveolar bone that he's still got a good amount of. And that's just made it so much more stable for him. So it really, really worked in his
favour.
Good,
and so this is an acrylic denture, yeah? Acrylic partial denture. And is it just replacing lateral incisor to lateral incisor, or are there any molars being replaced as well?
No, so he had no teeth on the bottom apart from those roots from 2 to 2. Yeah.
Oh, so it was almost a lower complete denture, except just maintaining the 4 roots. Okay, understood. Now, those roots, are they left exposed, or have they got like a GIC on them or copings on them?
They've got a bit of GIC on them, yeah.
Okay, fine. I remember doing this as a dental school. We did like a metal coping to give it a seal, basically, and that's something that can be done as well. Okay, very interesting. And with complete dentures, a message for students and for you as well, Emma, is if anyone wants to go into the smile kind of stuff, aesthetic dentistry, cosmetic dentistry, call it what you want, the place to learn it is complete dentures. Because with the teeth and the wax, you can literally set the teeth wherever you want in time and space, right? You can make someone into Bugs Bunny, you can give them a severe overjet, you can give them a deep bite, you just design it how you want. And what you learn from experimenting, okay, what happens when I make my central incisors go higher, further forward, further back, you learn so much about tooth display when they're smiling. So a great place to start with learning cosmetic dentistry is actually with complete dentures. Did you know that?
No, I've never really thought about it like that, to be fair. No, I haven't really thought about that, but it makes sense, yeah, definitely.
It's an interesting one. I remember going to a lecture, like 1 or 2 years qualified, and someone said that the percentage of the population that will be needing, like one of those health surveys, like percentage of population that will be needing complete dentures because they'll be fully dentureless will be something like, less than 5%. So the kind of joke he made was, I wouldn't want to specialize in complete dentures. Yet I see like an increase with, thanks to social media and people like Rupert and stuff, and young dentists getting a lot of satisfaction from doing dentures and complete dentures. I think if you gain those removable pro skills, then I think it's going to make you very employable in the future by any principal, because it's a huge demand, and it's something that not all dentists are keen on. So it's great that you got that first one under your belt. what's the top
Yeah.
thing that you learned, or a challenge, or any reflection that you have on your experience of delivering this denture?
In terms of going through the process as a student, I would say, you're making your first denture. You're not going to be able to do it all yourself. I know for the bite reg, I did next to nothing really, because, the clinician had to be there, basically walked me through it. But what I would say is, don't be prepared to go in and do all of it yourself, because you won't be able to, but know the reasons behind what they're doing, if that makes sense. So make sure you've watched the lectures and make sure you know what they're doing, but you don't necessarily know how to do it just yet, if that makes sense.
That's right. You have to observe it a lot of times first before you actually internalize it. And sometimes when you read it on a lecture in a book, when you see it in real life, it's a whole different type of learning, and it's like a disconnect there, and then that part of the brain lights up where it all joins together. That's a great tip. And don't beat yourself up that you'll need someone else to basically do it for you for the first few times. But as long as you're making visual notes and actually thinking, okay, I'm gonna do this, and I'm paying attention, and always keep asking why. So I love that you said that. And then something to extend to when you get qualified, you're not sure, what record do I need to send to my lab? If ever you find yourself in a scenario where you're like, what do I need to send to my lab? Always think, what information, if the lab get this case, what information would they need to recreate the patient, basically. So of course, the bite registration is so that the lab know where to put the teeth, so that when they bite together, there's not too proud, not too shy. So in your case, what was on this gentleman's upper teeth? Was he a natural dentition or a denture?
No, he had a full upper acrylic already, which was fine, so we just replaced the lower.
So essentially, you had the lower wax block, the wax rim, and you melted enough of it and to the desired vertical dimension, however you figured it out. And as long as lots of teeth were touching at once, when you bit together, basically, that's essentially what you went for, I imagine.
Yep, you're correct, yep.
How did you transfer the upper denture to the lab?
So we had taken an alginate impression of that denture. So we sent that to the lab as well. And then once we had the record block on the lower all ready to go, cut some notches in it and used some impression paste, got them to bite together so that it could be, fit back over to the cast of the upper, if that makes sense.
So yeah, absolutely. So as long as the lab have the upper denture, the upper teeth, basically, and then they can work with that to create the lower teeth. But anyway, we're digressing. We can always say that for a removal process talk in the future, because today's episode and the notes that you'll be releasing for May. Now, May for my dentist group on the actual Protrusive Guidance app is Orthodontics Month. It's May the Force with you. But I feel as though to make orthodontics relevant for students and connecting the real world was very, very tricky. And I thought since the first year of the student scholarship, something connected is tooth morphology. And when else will we cover that? So I think tooth morphology is a great one to cover. You've got some great notes for it. So this month we'll be accessing Emma's notes on tooth morphology. And so they'll be able to download them on the usual place on the app, Protrusive Guidance. So go ahead and check it out, and all the other notes that you've added, and keep adding them every month. And we'll have a nice little library of Emma's notes, which are absolutely brilliant, by the way, Emma. So what questions did you have in terms of, for me and for Protrusive, in terms of connecting this theme of tooth morphology to the real world?
Yeah, so my first sort of question, it might be a bit vague. So it's great knowing your tooth morphology and building up cusps that are, anatomically correct, left, right, and centre. But how does understanding tooth morphology contribute to you in practice in diagnosing and the treatment of certain dental conditions, I suppose, putting it all together?
Do you mean certain rarer conditions whereby, there are certain conditions where they get tulip-shaped teeth and that kind of stuff, and certain rare genetic disorders? Do you mean like that, or do you mean more bread and butter stuff?
Yeah, more bread and butter, really, than anything, yeah.
The first thing that comes to my mind, Emma, is some people generally have got very bulbous teeth, bulbous molars, right? And because they have very bulbous molars, underneath those molars, there's these huge undercut spaces, right?
Okay.
That is a real challenge restoratively, because when if they get caries and you lose a marginal ridge, the matrix bands that we have to recreate that extreme curve can be quite challenging. So sometimes anticipating that, okay, this patient's got very bulbous teeth and therefore I might need to just slow down a bit and try and recreate my contact here. And that's the most common one I've seen, whereby patients, the kind of matrices that we have, we can't accept them for what they are. We have to kind of mold them and reshape them to try and fit that exact patient. So that's the first thing I had. The other one I can think of is certain populations, certain countries, they have anterior teeth whereby they're really curled up. What I mean is, upper incisors, do you recall that they've got 3 planes? They've got that gingival plane, the middle plane, and that incisal plane. Imagine that incisal plane being not really flat, but quite curled up. And you might notice this on certain teeth, they kind of curl in. And this can be an issue because if you do a class 4 composite, so a front to tooth filling, and you're trying to recreate this on this patient, but then that filling keeps chipping, but actually you realize it's because it curls in, it's now in the chewing space, and that lower front tooth, for example, the lower opposing tooth, is kind of sticky outy, then there's a whole mismatch basically, because prosthodontically driven teeth, what we're trying to do with prosthodontically driven teeth is try and reduce that failure. And so sometimes you might choose to deviate from away from the patient's more extreme anatomy to make sure that you don't get that interference in chewing. So if you imagine if someone's got a sticky innie tooth and it keeps bumping in while you're chewing, it's not going to be ideal. Maybe that's why some people chip and wear their teeth away. So those are the first 2 things I had. Ask that question again so I can just think of another example. It's an interesting one.
Yeah, I was also going to ask you, like, if there was any certain situations where you would change the morphology of the tooth restoratively. Again, maybe quite a vague one, but...
No, I can think of a few scenarios here as well. Okay, so you know that upper incisors have got cingulums, right? Now, this might be a little bit more complex to get your head around as a student, but sometimes you've got severe wear. You've worn a lot of tooth structure away through parafunction, through grinding, through acid erosion, and usually a mix of that, right? So now you've got less tooth material. Now, to restore this individual, you need space. You need space to actually put your ceramic, your composite. And so sometimes a technique that we use in restorative dentistry is opening the vertical dimension. Like what you do with a denture patient, you open them up, right?
Yeah.
If you did that on a dentate patient, and then you open up the bite, and then you're recreating the new shape of the upper incisors, for example. If you go with natural anatomy, then it's sometimes very difficult to get coupling of the anteriors. So what I mean by coupling of the anteriors is how do we ensure that lower front tooth, lower incisor, actually touches and contacts the upper tooth? So then you could do the whole anterior guidance and that kind of stuff. So prosthetically, when we're treating toothwear, sometimes we may choose to give the patient a bit more pronounced cingulums that are going to be a little bit flat or machined in a way to basically get that lower tooth to hit it, basically. Because without this more pronounced cingulum, you're going to struggle to get the coupling of the front teeth. Does that make sense?
Right. Yeah, that makes sense. So that's one situation where you would deviate from the norm and make that cingulum just that wee bit bigger.
Absolutely.
What you're after. Yeah.
Because to keep the teeth in occlusion at the front, the downside of that is, and why tooth anatomy matters, is imagine you have a wax up, some toothwear that you're treating, and then you do some treatment for a patient, but then the patient comes back and their S sounds are really struggling and they keep their lisping, for example.
Okay.
Lisping is a sign that perhaps you've encroached that space, because when you make the S sound, the lower front teeth get into very, very close contact to the upper teeth. Now, some people make S sound whereby the edges of their teeth come together, so they go edge to edge of their teeth. Other people, it's like lower front tooth, lower incisal edge to cingulum. And now, if you've done that technique that I've described, some people will start lisping the S sounds. And so in that patient, you put the articulating paper in, you get them to count 60, 61, 62, 63, and you see that mark and you kind of just adjust it away and you give them some time to readapt.
Okay.
And so that's why one time that actually the tooth morphology, which you may do for a certain reason, can impact speech. The other one I can think of is, have you heard of something called canine rises?
No.
Have you heard of canine guidance?
Yeah.
So canine guidance is when you get the patient to grind left and right, the only teeth touching will be the lower canine and the upper canine. It's a very convenient thing. Now, if you tell a technician, can you please design all these crowns so that upper left canine, upper left premolar, upper left second premolar, and the molar, everything is touching at once, okay? That's very technically difficult for a technician to do that, and for you to fit all these crowns and to be exactly like that. It's much more convenient to say, can you just make sure there's one tooth touching the whole way along, right? We have all these things about canine guidance. I don't want to get too much into the philosophy of occlusion stuff, but sometimes it's very convenient to have canine guidance. There's lots of whole other factors as well. Now, if you lost canine guidance and when you grind to the left, right, you're now in group function, and you've decided that for one individual patient where you're going to maybe increase the vertical dimension, do lots of complex dentistry, that you want to give them canine guidance, again, if you just give them a normal shaped canine, it may not be enough. And so sometimes you need to augment that canine palatally, and that's called like a canine riser. You've kind of given it more material so that it is steep enough, the angle is steep enough so that when the patient grinds, it starts hitting on the canine and that takes over the guidance. So this is when we basically design and deviate away from nature to try and give us a specific outcome that we design. In this case, example I just gave you is a canine riser.
Okay, cool. So yeah, there is a few different examples there of where you would sort of deviate from the norm or what they maybe would have had when that tooth first came through. So that's interesting. My next sort of question, just more one that I've always thought myself, I don't know if anyone else has, maybe my own notes from first year would help me with this, but how do you tell the difference between a first and second premolar when, someone's had ortho, they've had a tooth taken out and the space is closed? I find that really difficult, and I've had that in a patient, and you just feel a wee bit silly when, clinician comes over and changes your chart and, all the rest of it. So.
Okay, good question. For the lowers, by the way, it's super easy, right? Do you know why it's easy for the lowers?
No.
Okay. From what I've seen in patients' mouths over the years, tooth morphology is like a distant memory for me, like studying this. But one thing that always I remember is because when we're crowning lower first premolars, it's a challenge because the buccal cusp height is a normal position, but the lingual cusp of the lower first premolar is really lower down.
Yeah.
The reason why that can be an issue is imagine you're going to do 1.5 millimeters of occlusal clearance, and then you're removing 1.5 millimeters of that lingual cusp. You really have lost a lot of tooth structure in terms of percentage of height of that tooth, basically. So if you're looking at a lower premolar and thinking, is it a first premolar or a second premolar? You just got to look at, is there a huge difference between the buccal cusp height and the lingual cusp height? If there's a huge difference, easy, it's a lower first premolar. If it's less of a difference, they're relatively even, it's a lower second premolar. So that's the one I got. Even I struggle, Emma, with upper first and second premolars. If you look at a lot of the way the text has been written, it's like when you compare the two side by side, you'll notice this. When you compare the two features, you'll notice this. But when you just have one premolar, it can be difficult. So I would ask someone, what difference will it make, and why is it important that we identify this as a first or second premolar in that individual?
I don't know. Is that a trick question? Does it matter?
You hit the nail on the head, and I don't think it matters, right? Because you're here now. One premolar is removed, and so even I'm like first premolar, second premolar. So I would suggest that it's not very clinically relevant in terms of which one's missing. The only one I could think of why it would be relevant is forensic dentistry, right? Unfortunately, someone has some sort of a funky way of leaving this earth, and they need to now look at the tooth identification marks and whatnot, and they're not sure if it's three different people, and then they all had a premolar removed, and then they're saying, okay, well, this person had a first premolar removed. And it's the only time I can think of it, really. Whereas actually in the real world, even having that knowledge of it's a first premolar or second premolar, it's not going to change anything that you do. But I know that the first premolars of the upper have got sharper anatomy. Like what I mean is like they're more distinct, the difference in the buccal and palatal once again, whereas the second premolar are a bit more similar. But I couldn't tell you more on that. I'd have to hit the same books that you got basically to help me identify it. So for your exams, guys, check out Emma's notes so that you can nail it on the exam. But in the real world, trust me, you're not going to blink an eye whether it's an upper first premolar or a second premolar. Whichever's gone, good riddance. Yeah.
And I think, especially in your first year, if you have OSCEs in your first year, a lot of the time they'll just give you a tooth that's out of a head. I think it would be pretty cruel for them to maybe go for premolars, but you never know. You never know what they're going to do.
A common one I remember for an OSCE years ago, right, is an orthodontic OSCE is they will tell you to chart the dentition of someone who's like 9 or 10 years old, or maybe someone with a retained deciduous second molar. Let me say again, retained deciduous second molar, because that baby second molar, especially lower, it looks a lot like the first molar. And so sometimes you might confuse it as the first molar. And then you might incorrectly identify the second molar, in the wrong way. So that's a common one, identifying the deciduous second molar and the first molar of adult dentition and making sure you get that right.
Yeah, definitely. That's a good tip there. I think they love a good tooth morphology in first year especially. So, no, that's a good one. I wouldn't be surprised if I had something like that this year in third year, though. We've done
that would be, I think, a very classic one, actually.
So.
I think a top tip for students, and that's quite a common one I've seen in exams in general, and that's a skill they want you to have, not to confuse a baby tooth for an adult tooth. And so which baby tooth looks very similar to an adult tooth is exactly that scenario.
Yeah, or sometimes they'll throw a hypodontia in there or something as well, which is definitely a good skill that you need to have, being able to spot that. Yeah, lots of wee good tips and tricks there. But another question that I had, which the answer again might not be, oh, it's not that important, but are there preventive measures or interventions, I suppose, that can address issues that relate to teeth wear and preserving natural tooth morphology? Like, is that something that's important, I suppose?
It's a really, really interesting question, actually. So, I mean, the angle that you're coming from is how can we prevent wear, but specifically in relation to tooth morphology.
Yeah.
So that's an interesting one. So firstly, I the first thing I thought of when you asked that question is generally prevention of tooth surface loss over time. What can we do? And if you look at different materials and how they behave with each other, for example, the differential wear rates. So for example, if we take cobalt chrome and we take enamel, what if enamel is opposing cobalt chrome? How well do they interact with each other? Does the chrome absolutely destroy the enamel, or does the enamel destroy the chrome? Actually, polished cobalt chrome and enamel for very similar wear rates. They will really be good over time. However, if you have a chrome opposing composite, the composite will lose in a big way. So as they chew and grind and whatnot, the composite takes an absolute beating and will wear down, whereas the chrome will not. So how is that relevant to your question? Well, enamel to enamel wears very similarly. It's the same material, right? So actually, pure attrition, let's say pure tooth grinding, clenching, tooth-to-tooth rubbing, if it's pure attrition, it's not going to be so damaging, right? Over time, yes, the teeth shapes will be very sharp and defined, and you see those wear facets, but it's, it may not even go into dentine over someone's lifetime if it's just purely attrition. The issue is we very rarely see pure attrition because of the abundance of extrinsic acid, so our diet, and intrinsic acid, so things like reflux and stuff. And so when you put a drop of lemon in the equation, that attrition really accelerates. Then you're going to get into dentine and all sorts. So the way to think about it is, what's your biggest cause of wear throughout life? It's a combination of erosion and attrition. Of course, there's toothbrush erosion as well, but that typically happens on the sort of gingival areas, not so much on the occlusal, right? So having said that now, what can we do to prevent it? Diet advice. And for those, now we're getting into sort of more occlusal philosophy, is if you set up someone's bite right and in a minimally stressed dentition, then when they grind left and right and stuff, everything's in harmony, and therefore they're not going to wear through so much. But a simple thing is, people who wear retainers due to orthodontics, and they wear those plastic retainers, we know that their teeth will not change very much, right? Because any grinding that's going to happen is going to be absorbed by that plastic and not by their teeth. And there's these great dentists, like for example, a really famous dentist called Didier Daichi, who shows 30-year follow-ups of some of his composites at the front, which is crazy, right? And then they look brilliant. But he actually says, the reason why they look good, the reason they haven't worn, is because my patient wore her night guard every single night for 30 years, right? And so there's a lot to be said about that. Finally, to answer that last point of question, which is the most important distinction, which is, how does tooth morphology come into it? If you have very delicate anatomy or very, let's say, boisterous, voluptuous anatomy, I guess the best way to say it is mamelons, right? If you've got mamelons, right, on your incisors, how often do you see people, right, beyond the age of, let's say, 8 or 9 with mamelons? Yeah. You don't, right?
No, not really.
You don't have mamelons. I don't have mamelons, because it's a very delicate, sticky. It's a bit like, when you you're at school, you get a brand new eraser, a brand new rubber, and then you start using it to rub some pencil marks away. You look at it and, oh my God, I've lost a huge chunk of my rubber already, right? But then that rubber will last you until the entire primary school. You won't get through it because the surface area of rubbing is so much now, right? So mamelons are kind of like that tip of the eraser. They'll wear away like within a month, right? They'll go from acid erosion, bit of wear, basically they'll go away. but then the meat of the tooth will take some time. So how do we translate that into your question? Well, when we are rebuilding someone's dentition, so let's say you got toothwear, and then you're going to open up their vertical dimension, technically, we are now fully in control of the future anatomy. We can wax it up any way we want. We can make the teeth look any way we want. Are we going to copy nature exactly? Probably not. Because having those delicate cuspal slopes, having those mamelons, having those very sharp canine tips, they're just going to get worn away. So sometimes we go for like a age appropriate, right? We get age appropriate and we veer away from things that was going to just rub away or fracture basically. And so that's a long way about saying is, yes, sometimes when you're waxing cases up in a restorative, we're going to not give someone, a 10-year-old's incisor. We're going to actually focus more on, okay, once that's been worn away, what's the main primary anatomy is what I'm getting to. So maybe you won't give the whole tertiary and the delicacies. You focus really on the primary anatomy. So if you guys can really focus for the exams, learn everything. But for the real world, if you nail your primary anatomy, and then secondary anatomy, the most important one being line angles. Do you know what I mean by line angles?
Yes, I think.
Emma, what you'll learn is that if you ever say yes, then you have to tell me what it is.
So is this when, once you've cut a cavity?
Okay,
no.
So I see where you're coming from. No, not in this context I'm coming from.
Okay, then no.
That's okay, and I want you to keep trying, because line angles, I don't think is something that was in the textbooks, Line angle is something I learned on the composite course, but it is actually tooth anatomy. Okay, so lateral incisors, right? If you look at them carefully, there's a point where the labial sharply turns into the distal and the labial sharply turns into mesial. And if you follow that along from gingival to incisal, it makes like these two lines. So these two line angles, these transition lines basically.
Okay.
If you are doing anterior dentistry, so the next time you do a composite on the front tooth, or the first one that you do, for example, I'll say we should really brush up on getting that line angle in the right position. Because if you don't have that line angle, teeth look like Tic Tacs. Teeth look like flat blobs. It's having those line angles which gives your incisors character and anatomy. So being really good at line angles when you start doing anterior dentistry is really important. And that's something that is part of, primary and secondary anatomy. The whole tertiary anatomy stuff, no one ever shows it. It's for Instagram. And definitely, I wouldn't go around making mamelons and stuff. And things that are, from an engineering perspective, if you're treating a toothwear case, you want to build it up for success and longevity. And although, yes, nature is beautiful, nature's intended, sometimes nature has elements where you don't actually want to copy because it can be too fragile.
Yeah. And that did actually sort of tie in with my final question that is written down, which was about, if you have a patient coming to you and they've seen your work on Instagram, but you've decided, this is a heavily worn tooth, you're not going to rebuild it like a natural morphology. Is that a conversation you would have with the patient? Is that something that would be built into a consent form? How do you communicate that if they've got this expectation of walking away with a tooth that looks, brand new as soon as it erupted, and they're not going to walk away with that because it just wouldn't be right?
Emma, I'm really proud of you for picking that question. I think it's a very intelligent question. Okay, I'll tell you why. It took me years to realize that when I'm removing an amalgam, right, which is invariably was a flat amalgam, right? I removed that flat amalgam, got my rubber dam on. I spent ages trying to think of the textbook and trying to work my beautiful anatomy. And then I take my rubber dam off and I'm there for 10 minutes drilling it out of the bite again because it was too proud, right? And then it ends up looking like the initial flat amalgam, right? And it took me years to kind of figure out what was going on. And so the mistake I was making there is I was trying to give this individual a tooth that was not compatible with the opposing tooth. Because if you start with something flat, then you got to look at the opposing, and actually, unless you change the opposing as well, and then eventually, you got to look at the hole around the mouth, basically. If you're trying to conform and keep the person's bite roughly the same as it was before, then we can actually end up running late and embarrassing ourselves and losing control of the occlusion if we start to build all those natural cusps. So what I believe is, and it ties in well with the question, is we need to use the books and posterior tooth morphology as inspiration. Use that as inspiration, but what we give the patient will depend more on A, what the tooth looked like at the beginning before we started, B, what the opposing tooth looks like, that's going to actually slot into it, and then how they mate together, how they fit together, and then that's going to take precedence. You can still use the outlines and the way you shape the angle, so it roughly looks like the kind of tooth, for example, when I'm doing a lower molar, I would kind of give it 3 buccal cusps and 2 lingual cusps, I would do it basically, but they're not going to be as voluptuous and as proud. It'll be kind of so like sometimes they can be quite curvy cusps. Sometimes they kind of be like chicken scratches that you put in with a probe, right? Because that there's no way that you can give that tooth anatomy and it still fit in that patient's bite. If you give a 60-year-old who's got 250 years worth of tooth wear, and we'll talk about that in a moment right here. So if you give a 6-year-old who's got significant tooth wear, a 12-year-old's tooth, it's just not going to work in the bite. So I think we should use the textbook as inspiration. So your question in terms of what do we actually tell the patient, if you have a patient who tells you that they want their lower molar to look like anything, run away. Run a million miles away from that patient. This is a red flag patient, okay? Usually, if it's tooth color restoration, okay, and then they move their cheek out of the way and they have a look, they're going to be over the moon, right?
Yeah.
So thankfully, we won't have to worry about that scenario. Now, I have had a patient before, Emma, who came to me and she drew on a piece of paper what she wanted her contact points to look like between one premolar and the other premolar. Like I was doing her class 2 composite and she drew for me what she wanted her contact points to look like, okay? This woman was nuts, all right? So I'm not saying you will get the odd funky patient, okay? And then maybe at that point, you got to take photos, intraoral camera photos, like, look, I'm going to give you the best I can that's going to fit into your mouth, but I can't make you look like Julia Roberts if you're, whatever side position, basically. So your point is valid, but thankfully, that's posterior teeth, you know what? Patients are going to be okay as long as it's tooth colored and they're usually blown away by it, basically, in my experience. But remember that the textbook for inspiration, but actually what takes precedence over that is how it's going to fit in that individual's actual occlusion, and which invariably means flatter teeth, less sexier teeth, and uploading it to Instagram when the rubber dam is still on. If you take the rubber dam off and done the adjustment, it's not going to make it to Instagram, unfortunately.
Yeah, that's the real world, I suppose.
It's the real
that's
world.
Good to know, because you strive so hard to, in the second year I was carving amalgams and polishing amalgams on the phantom heads and things, and it's just, you go in the clinic with real patients and it's just not how it is, and that can be frustrating because you've learned all this perfect anatomy and you want to be able to replicate that, but sometimes it's just not applicable, I suppose.
What I don't want to say is, I don't want to sort of suggest from this episode that actually tooth quality anatomy is irrelevant because you got to go with the patient's own anatomy. Yeah. I think it's great for inspiration and to get, your restorations will look so much better if you get those 3 primary cusps buccally and 2 lingually rather than just splodging something completely flat there, okay? To give some sort of anatomy is good. To have cusp tips and fossae does improve masticatory efficiency, so please do strive for it, and it's good. But you got to take a pragmatic approach. And when we're doing more like worn teeth and we're rebuilding everything up, like you're doing more of a full mouth kind of job, right? At that point, you get to design it how you want. And so you want to design it with more natural anatomy, taking inspiration from the textbook, but you still want to design it in a way that if you don't want to have too steep a cuspal angle, because a too steep a cuspal angle means that cusps will crash into each other. It puts more torsional stress down those cusps and whatnot. So it kind of needs to be minimally stressed at the same time. But the more you learn, if you want to improve your composites, if you want to improve how they look on posteriorly, if you spend some time to really study what tooth anatomy looks like, your composites will look absolutely beautiful. Just by positioning exactly where a cusp begins and where it finishes, even though it's a flatter one to match it, your composites will still look beautiful. Yeah, no, that's good. So take your books as your inspiration and go from there and see what fits in your patients. So, no, that's good to know. Absolutely. Brilliant. And what I would say is when you're in the clinic, top tip is always check the occlusion before you start. I think we talked about it last time. Yep. Get a thin articulating paper. Don't get the big fat blue wad, because what's going to happen is a patient might scare the entire tooth goes blue and you think, well, hang on a minute. Where are the bite marks? If you got thinner occlusal paper, you see a couple of 3 or 4 dots basically, and you're roughly trying to copy that into your restoration. That will save you a lot of time and sort of adjusting away at the end, basically. Yeah, no, that is a good tip. And it's something, I did a tiny wee composite on lower central last week, but I did that before I checked the occlusion beforehand. It was an old one that had popped off or something, but no, that helps me because after, the patient's occlusion was actually quite like almost edge to edge, and then the clinician came over and was asking about articulating paper and stuff, and you got to grind that down, and I was like, I checked it beforehand, and they were really happy with that, so I got a wee gold star there. Really good, Emma. I'm glad our chats are paying off, which is great. And I think hopefully we can pass that on to everyone as well, which is great. Basic thing, but even dentists getting a bit in the real world. You only got like half an hour or something to restoration. You're like, okay, LA, quick notes. Okay, let's go in, just remove the caries, let's do the filling basically. But it makes so much, it will save you so much heartache, and it helps you take pride in your work. Try and work with a degree of precision to get it happy in the bite and to appreciate. Sometimes a tooth is not even in the bite, right? And then if you didn't know that and you try and build it into the bite, but it was never in the bite in the first place, and there's no real need to do, in certain cases, that kind of stuff, that's going to save you time as well. So glad you emphasized that. In terms of next month, I'm just having a look where, it's crowns and onlays month, okay? So Emma, I want you to think about some questions for crowns and onlays. I think we can actually make something really juicy here. I mean, there's so many different ways we can go. And I'll let you, as our main protrusive student, to suggest which notes would be good for the students and what clinical questions you want to ask me so that we can actually connect the students in the real world together, basically.
Yeah, good. Because I'm not giving anyone a crown or anything yet. So
have you covered the theory of it? Have you done it on Phantom Heads?
Yeah, we've done them on Phantom Head and things. So I'll cook up some good questions for that one next one.
Good, and we look forward to checking out your notes as well. So thanks so much, guys, and I'll just catch you in the outro. Thank you, Emma.
Thank you.
There we have it, guys. Thank you so much for listening all the way to the end. Remember, we have the student forum section on Protrusive guidance, which is, something you can access on the laptop, protrusive.app, or download the Protrusive guidance app. It's on iOS and Android. And like I said, if you email student@protrusive.co.uk with your proof of being a student, we will give you access to a little secret area, which is usually a paid for area, but just for students, as a way of giving back, we're going to make this happen for you. I look forward to growing this segment of the podcast with you guys. And thanks so much for all your comments and engagement on YouTube, as well as Spotify, and of course, our Protrusive guidance app. Catch you same time, same place next week. Bye for now.